Welcome, everyone. You've made your way to the monthly psychedelic support speaker series. And today, our special guest is Dr. Darron Smith, who I will introduce in just a moment. But today, we're going to be going through some questions. And as I go along, if you have questions yourself that come up that you would like me to ask Dr. Smith, you can drop them into the Q&A box, which is located in the bottom of your dashboard there. We also encourage you to chat in the webinar chat feature here. We'd love to know where you're calling in from. And as we're having this discussion, you might want to drop in some more information. I'm going to be putting some links into the chat as well with additional resources. But that's what this event is all about, is coming together, sharing information, and connecting with others that are interested in this topic. So today we're going to be discussing the need for anti-racist training in psychedelic therapy. And we have a very experienced speaker here. Dr. Darron Smith is a physician assistant and a U.S. Army veteran with over 20 years of healthcare-related experience as an educator and mental health treatment provider in psychiatry. He has trained with MAPS for the MDMA-assisted therapy protocols, and his research and scholarship has focused on U.S.-based systems of racial oppression and systemic inequality found in all societal domains, including healthcare, the family, healthcare disparities, religion, sports, culture, and politics. Dr. Smith's current research and practice intertwine the study of applied neuroscience, race-based trauma, and mental illness by looking at the impact of EEG biofeedback versus MDMA-assisted psychotherapy on brainwave activity in individuals with racial trauma. He serves on the advisory boards of several different organizations within the psychedelic space, and we are so grateful to have Dr. Smith here today to help educate us on this very crucial topic for psychedelics, but even beyond. So thanks for joining us, Dr. Smith.
Thank you for having me here. Please call me Darron. Please.
Okay, Darron. So before we kind of jump into the specific topic of psychedelic therapy, I wanted to ask you a kind of more broader question about what are the cultural barriers preventing Black, Indigenous, and people of color from accessing and seeking mental health care in the United States here?
Well, that's a great question, and it stems from a long history of racial marginalization, a long history of race-based exclusions that the BIPOC community from whatever centuries have had to endure. The cultural barriers, one being, not having enough providers of color to service those who need mental health services. Not having enough trained individuals who are available to render care, because of course there's a shortage of mental health practitioners in this country, and there's a maldistribution of where they are. Most live most in the cities and in the urban areas, not so many in the rural communities, and so we have a maldistribution of where resources are available. And of course, you also have the ever-present reality of dealing with race-based discrimination, or its history is rooted in white supremacy, and of course this idea that whites created, or white Americans created, a system and a structure that really serves white interests, and generally at the expense of other communities. This is really what this is about, is these legacies of marginalization that have existed, that I know a lot of, when white folks hear these things, it kind of cringe, like, ooh, it bristles. But we're not talking about individual acts of meanness, one so-called race against another. We're talking more specifically about institutional, centuries old, structural, racist practices that have been embedded within institutions, within every major domain, from healthcare to Hollywood, you name it. And so trying to find some inroads and trying to find spaces where various cultural expressions are accepted and welcomed it's been a very long, very difficult road But I'm hoping with what's coming down the pike with these new entheogens that we have available to us soon, hopefully soon, we'll have more tools to throw at this very desperate problem of healthcare inequity, particularly in mental health.
Yeah, absolutely. There's so much work to be done in this area to have equality, which I believe that a lot of people would really like to see implemented across the board in all these domains. Another question that I have is, I'm a researcher. I've been participating in clinical trials as an investigator for a number of years. And I would like to hear your understanding of some of the barriers there for participation of BIPOC individuals in research, but also in psychedelic clinical trials, which we know have predominantly been enrolling white participants in these phase 2 studies that have been going on for a number of years now.
That's a great question. So what we know currently about the impact of psychedelics on communities, we know from white participants. It's just been a very, very, very difficult road to hoe to try to get BIPOC members to participate in studies. That stems from a long history and a long legacy of racial discrimination. People of color being used as experiments in medical experiments as well as military experiments. So this history of scientific racism, looms large in the minds of BIPOC individuals, particularly African Americans, given that what we know about some of the earlier studies that were done on, with these entheogens, particularly with LSD, psilocybin, were first experimented on with people who were housed in mental facilities, mental hospitals, who had no voice, who had no way of speaking for themselves. Of course, this has all been changed now, but it wasn't wasn't in the far too distant our past where these practices, dastardly practices were allowed to go on. And so what we've learned about a lot of the characteristics of these medications or these uses of these substances, we know from the bodies of unwitting participants who were used in the earlier phases of trying to understand what these plant-based, wonderful, adjuvant, substances will do for patients. And so that's one. So we have to do more to dispel distrust. We have to do more to lift the community up. We have to do more to provide resources to the community in terms of, what's easy for white participants to do in terms of enrolling them in these clinical trials takes a little bit more effort to do for participants of color. We have to get creative, right, and figure out ways to bring people into some of these important works. I do want to say that some of the earlier phase 2 studies that were done by MAPS relied heavily on white participants being the most predominant group. But there's been some recent studies that have been done. I know one that's just recently come out, MAPS-2, and the MAPS-2 study, they enrolled 53% of their participants were people of color, were BIPOC individuals, and so that data is currently being written up. So we'll be able to see, what it looks like in the next month or so once it's published. I suspect we won't see much difference than what we've seen in white participants. I think there's been some really pretty good case studies that have been done on this, which have indicated that people of color do just fine on these substances. In fact, they have, in some cases, do even better, in some instances. And so I think this information will give us some really good, at least some scientific evidence that these are very helpful for not just white people, but for everyone. So that's the goal.
Yeah, absolutely. It's so important to study a variety of people, a range of demographics in clinical research, because if you have a drug approved, you want to make sure that you're going to have the same effects or their potential unwanted side effects. And, could it be genetic or cultural differences between people? And teasing that out during the clinical research phase is very important for safety and efficacy. Do you have any idea of how MAPS was able to increase their enrollment to more diverse population of people?
As a matter of fact, I do. They actually created like a task force, and they brought together some individuals in the field who were trusted and and who worked in spaces where they had access to larger segments of BIPOC members, and so they designed a neat little research protocol that they used, and some of it revolved around paying individuals to participate, and then making sure they had access to and from the facilities where this was occurring. So they made concessions there, or they were able to add that into their budget, their overall budget, when they put together. So I think that those two things alone have been very helpful. I think a lot of it. Joseph McGowan played a big role in almost single-handedly bringing in, just more than a gaggle of people in this particular study that will be published here. So I think they got creative essentially and did some things that thinking outside the box. And so I think that's what it takes in order to get BIPOC members to be interested in studies with such a long history of just we are scientifically poorly designed studies, shoddy methods, breaking all kinds of ethical guidelines that we wouldn't dream of doing today. But this is a good step in the right direction. I'm actually quite pleased. I'm MAPS, if you're listening, I'm not on the payroll. I would maybe like to be, but at any rate, the point is, I think MAPS has done a good job of sort of coming to terms with the fact that early on in its iterations of training facilitators, maybe it wasn't, training facilitators in ways that spoke to BIPOC members. But I think they've done a great job in looking themselves in the mirror, which is often the first step, and then and making adjustments then, from then on. And they've done that. And so I think now we've seen hopefully the fruits of that with this cohort, which is 53%. BIPOC members. So this is fabulous. So I'm just waiting with bated breath to see what what the numbers bear out. So.
Right. Yeah, it's very encouraging to know that there is a path forward to changing the demographics of a study, of enrolling more diverse population of people by training and hiring therapists that are diverse themselves. I know I want to acknowledge Dr. Monica Williams, too, who was brought on early on during MAPS phase 2 trials. She's a researcher and practitioner that focuses on racial trauma. And, a lot of what she brought forth was things like, your recruitment flyers as well. You want to make sure these are welcoming and help a participant understand who they may be seeing if they come to a trial. If you're trying to recruit lower socioeconomic individuals to your study, what might be a barrier with psychedelic research trials? It's the long sessions, 8 hours, additional therapy, prep and integration, coming to a research site, that staying overnight potentially. All of these things could make it very difficult for someone to enroll. So I feel like there has been a lot of light shed on how to make studies a lot more inclusive, and starting at the demographics of the people hosting the study, therapists, involvement, study coordinators, and all of that. So that's wonderful to hear the changes that have come from phase 2 to phase 3 with the population there.
So let me add this little bit of information. It's because of Monica's work, right, that the changes that MAPS instituted came about. Monica's critiques, Monica's very, very forthright, truth-speaking, sessions with the MAPS officials about this. And so what we have now is sort of an outgrowth of that. So yes, yay, Monica, we love you, Monica.
Yeah, she's wonderful. I just dropped the link to her website. She's highly published, lots of books and publications on this topic, if anybody wants to go further into that research and connect with her there. Okay, so I'm going to back up a little bit into, let's get a little bit more in the details about some of the structural barriers in medicine and psychiatry that are preventing BIPOC individuals from accessing care?
So I think we touched on some of them earlier, but more specifically, I think that again, the history of the United States, the way in which our systems are systems of ways and beings. Medicine, for instance, was situated or structured, built upon beliefs about racial inferiority. One group being better than another, one group having a third muscle and the other group didn't, which gives them more ability to run, jump, and be more athletically inclined or more willing, and having a dancing muscle and all, what have you. None of these things are true. And so I think medicine starts its beginnings, its foundations on shoddy ground, racist ground, essentially. And so it's taken medicine a long time, modern medicine that is, to reconcile that, to come to terms with that. And I think there's still huge, enormous gaps in the system, but I think there's been some movement to try to make it better. So one way is, as I indicated before, is we don't have enough practitioners of color. That's just flat out. We don't have enough. Perhaps with our underground colleagues, we would have more, right? And if there was a way to make our underground colleagues come from the underground into the to above ground, that might help with some of the massive people who need mental health services. And so that's one. We need to train more people. We need to be better at distributing resources in the community, because we don't have enough people who are available for resources. We need to get creative. We need to continue to use telehealth, telepsych services whenever possible, except for when we're doing psilocybin assisted therapy or PATS therapy with individuals. Because the research bears out it's better to be there in person, holding space for people that way. So I think training more people, making sure people are located in proper places, creating scholarship opportunities for individuals who would be interested in becoming a facilitator or a therapist. There's ways. There's the education track that most people follow to become a therapist, whether it be an LCSW or whatever it is. And then there's the sort of the fringe, I wouldn't call it a fringe, but kind of the not as recognized way of doing it, right? Going to certification workshops, getting trained here and getting trained there. One of the things that I find really interesting is what Oregon is doing with in regards to this, in terms of accessibility. One way to conquer accessibility is by training more people, by making people more accessible to those that don't have access to mental health facilitators, particularly those who are BIPOC members. It might entail paying people more money. We have to think about that to entice people to get into these fields. So I think medicine has long neglected people of color and their needs. And I think, again, I want to say that I think that I would hope that looking forward, there's been some significant movement in the right direction in terms of remedying past wrongs. But only time will tell. But right now we're in the middle of a crisis. One of the crises I want to say, just this thing before I forget, is one of the big issues we're struggling with right now is teen suicide. Particularly African-American suicide rate has gone up significantly since the pandemic. And so there's an epidemic there that's not even been discussed, in much amongst the circles that I run in. And so we need to do better at that, and learn how to hold space for people, particularly people like me who are prescribers, right? You come and see me, I write you, here your prescription, boom. And I can tell you right now, giving people medication doesn't work. In and of itself, it just doesn't work. It has to be coupled with something else: therapy, breath work, yoga therapy and breath work, neurofeedback and something else. It needs to be coupled with more than just one modality in order for people to have, different ways to attack the things that cause them, to feel depressed or to feel anxious or what have you. So I would say that we can do a better job. Medicine can do better.
Absolutely. Absolutely. I can't agree more. At Psychedelic Support, we do offer a diversity scholarship twice a year for our educational offerings. And I dropped the link there in the chat if anybody is interested in applying. So on to our next question here is, what are the difficulties or risks that BIPOC clients face when they are unable to work with psychedelic therapists and doctors who look like them?
Ooh, harm. The potential is harm, right? And so, the whole purpose is harm reduction, right? And so, oftentimes BIPOC members have no choice but to work with people who don't look like them. And oftentimes the reports come back that they've had horrible experiences, particularly when they've tried to express and speak their truth about being a member of a marginalized group. And so, the focus, has never really been on, the importance of harm and the importance of holding space for people who are potentially vulnerable to the effects of harm. We all are vulnerable to the effects of harm, but some more than others. Just by virtue of waking up in the morning and looking in the mirror and saying, wow, I have more melanin in my skin. Wow, right? And that's going to subject me to more microaggressions than the average person, simply because I'm a member of a BIPOC community. So
can you explain what that is for the audience, microaggressions? And
yes, absolutely. So microaggressions would be, it would be like a modern form of racial insults, right? People who, microaggressions would be little insults, slights, jeers, daily mundane effects of living in a racist society. Things like hair touching, can I touch your hair? I hear this a lot from transracial adopted parents who are raising Black children, right? That a lot of their friends often want to touch their child's hair, right? So that's really annoying. So that we call that a microaggression. Or maybe it would be ignoring someone in a meeting, maybe at a meeting, and you're raising your hand to give input, and maybe you're purposely being ignored. Maybe it's that, maybe it's driving while Black, being pulled over more disproportionately because you're Black. So these kinds of daily insults that BIPOC members have to face simply because they are members of a marginalized community.
Right. And I've read some of your research talking about stress that compiles over time, whether from microaggressions or conscious systemic bias that happen, and the epigenetic possibility of what could be happening there. And so I'm curious of when someone undergoes a psychedelic experience, would you expect, or is it possible that some of these experiences might come up or become more vivid, or this psychedelic altered state?
It depends on what the intent is. It depends on a set and setting makes so much of a difference there too, but also the intent of the individual who is going through the experience. If race is something that's pressing on their mind, perhaps it might show up. But the therapist needs to be able to, if they know nothing about race. Most people don't. We don't have any formal classes on it. You're not required to take a class in college on it unless your department required it. But most of us have really kind of, in terms of teaching the stuff and having real serious dialogue, that's really out the door. So we pick it up where we can. And I would argue that most therapists probably don't have much experience with BIPOC communities. So, and if that's the case, I would invite you to simply hold space. And just simply hold space for clients and be there for your clients. There's some additional strategies, but I would, if nothing more, that's just being there for them, holding space for them is sometimes all you need to do. But it's nice if you have a patch therapist who's actually who has experience working with those communities, who can certainly know how to spirit a client to and fro as needed, or perhaps work with or gently nudge a client to stay inward as opposed to focusing on outward things. If a racial a racial microaggression manifests itself. Now, this is where Monica's work comes in. The chronicity of these events that happen time after time, over and over again. It's not the one event that might be the tipping point. It's the death by 1,000 cuts that occur over the course of one's life that experience these things. And one of these events might push someone over the edge into a full-blown PTSD. So that's why we need to be very circumspect and very, very aware of what we say to people, not be afraid, but be recognized that through no fault of our own, our ignorance is in part is what drives disease, believe it or not. The lack of humanity that we feel at times for one another, the way in which we've been socialized to believe about one another, and we always fail to forget that we are Homo sapiens. We all belong to the same species. I don't know how many times I have to say that to my students. That look no further than bonobos, our closest related relatives, our closest cousins. And humans, we're just an ape without any hair, but we are no doubt an ape. And the things that we do to one another, the way that we partition each other on that basis has caused so much death and destruction in the world. It has caused so much unnecessary complex trauma that people face and are vulnerable to. You mentioned epigenetics, and how people who have been systematically abused and enslaved for 400 years or 350 years, right? That just doesn't go away, right? So the epigenetic scars are in place for generations of people who've experienced slavery and continuing discrimination, not just slavery, but ongoing discrimination. And so, it tends to wear people out. It's called weathering. It tends to wear people out where folks of color die sooner, succumb more to diseases, lifestyle-related diseases, right? Things that we actually have some control over. Diabetes, heart disease, certain types of cancers and what have you. Many of those diseases are caused by living in a modern society. It is not easy to live in a modern society. And you add on top of it race or gendered identity, for instance, or other descriptive terms or characteristics of one's personhood that goes against the grain of what people determine as normal. Can erase years off your life and can cause the stress hormones to be constantly elevated, particularly cortisol. So yes, there is definitely a neurobiological component to all of this.
Yes, absolutely. This is kind of a good lead into one of the questions from a participant. They're asking about, could you speak a little bit more about how race-based trauma can differ from traditional PTSD in terms of symptom manifestations and definitions, and how BIPOC can identify and articulate what they are experiencing?
So I would urge you to, for lack of a better manuscript, to refer to the DSM-5 is all we got, unless you've got some other ways, clinical experience, but really provide the definition of PTSD. And so what the new iterations of the DSM-5 say argues that that PTSD can also be had by watching things, by witnessing bad things happen to people, right? Or you can have PTSD occur just by hearing someone talk about it. So seeing it, hearing it are ways that can trigger PTSD in an individual. So the mechanism of action as it pertains to race-based trauma is the same as it is with PTSD. The only difference is the trigger is race, right? So the constant forms of dehumanizations I mentioned previously, the ongoing nature of that over time, right, can push someone over the edge into a full-blown PTSD, which symptoms are very similar. So they're not the symptom. So the symptom presentation of a patient that comes into your office is going to be the same if the person had PTSD versus the person had race-based PTSD, right? So I would urge to get into the weeds with these patients, but sometimes I get mixed between client and patient because I'm in two different worlds, but you know what I mean. It would be nice to kind of get to understand yes, definitely. Dr. Joy DeGroo's work is phenomenal, looking into post-traumatic slave disorder. So, and also my dear colleague William Smith's work on racial battle fatigue, and also, of course, Monica's work on racial trauma. So there's lots of people to look at in terms of understanding the sort of the mechanism of action and dynamics of this process that occurs. It's something that is hard to explain to people, when you talk to people about this and you say, this happens to me, people kind of sometimes say, well, really, are you maybe you're just imagining things like that? Well, it can't be true, right? Because they don't experience it, right? So, and discounting people's experiences is another sort of microaggression, is discounting experiences. And so, yes, Jamie is killing it over here. That's right, Jamie. So
yeah, such a wealth of information here. And, there is a parallel too with some of Rachel Yehuda's work looking at epigenetic modifications from individuals that were, their parents were part of the World War III or World War II and Nazi, and some of the instances that happened there. She was able to study children of people that were in prison during the Nazi regime there. And they were able to measure actual changes in the cortisol regulation and how the body interprets that. And in some ways, it does seem like these generational effects can be carried down to perhaps prime the body to be evolutionary, maybe more prepared for a stressful environment. But it could also make someone be more hyperactive toward stressors in their environment, or the nervous system is primed to be more responsive in ways that perhaps make someone more susceptible to PTSD if they were, say, as a child in a very stressful environment, or even in utero. I think they were showing effects with that as well. So even before you're born, your environment may play into how you experience the world. So there's a lot of congruent information across the neurobiological effects, cultural effects, and what's being observed in different patient populations. So I'm going to move on to the next question here.
Okay.
Yeah. So I think we've really hit on like the need for sure of why we need to have more therapists of color, more opportunities for training. How do you think we're going to get there? Like, what are some practical ways to reach more people of color, encourage them to participate in this psychedelic renaissance, or potential applications for psychedelic therapy in medical practice?
I think that we need to make sure that we sound the alarm. We ask people, we ask our friends, we educate our colleagues about this. We spread our tentacles. We try to recruit people that we know who are in this space to maybe provide some insight and guidance as to how this might work, as well as I would also argue that we have to go out and grow folks. That one, two, we have to go, bring folks from the underground into the daylight, so they can actually practice their craft. There's different ways to do this, but this is a profession that we're brand new, and so we're having these discussions early, very early, whereas most professions have not done that. They've waited to after the fact. So the fact that we're having this conversation today is a great launching off point, but it's a lot. There's the work is so overwhelming that it's hard to isolate which particular piece you want to hone in on, right? So I think that has to do with your particular interests and the things that move you. For me, it's the research. I think my colleague here I think feels similarly in terms of our understanding of research and the importance of research and shedding light on some of these important ideas. And so I think what MAPS has done is fantastic. I think them reaching out and trying to find acolytes to help bring into more into the fold, having scholarships. You mentioned scholarships. So there's a group that I work for in Oregon. I want to give a shout out to the Alma Institute in Oregon. We're one of several training programs there, and we are training this brand new, very new profession called mushroom facilitator. What an honor. I'm honored to be involved in this, to train these new group of practitioners. And these are people who don't necessarily have any additional training. These are people who are 21 years and older, who have a desire, who want to help space for people in the past, to train them in terms of how to work with clients. There are some obvious, great idea, love the idea. It's very anti-medical model. And it allows for greater opportunity to bring in BIPOC people. In fact, we have our executive director, Rebecca Martinez, is all about bringing in BIPOC individuals into the space. So we have quite a few scholarships for people who, individuals who want to be mushroom facilitators. Now, let me tell you about the mushroom facilitator job. It's going to be designated as a new profession very soon with the Bureau of Labor, a BLS. And I think you'll see this begin to spread across the country, particularly as states start to decrim these substances so that more people can have access to this. And so I think we're going to start to see a lot more trainings like this. I know there's several different institutions now who are training people to work with ketamine. That's about all we have right now in terms of legally to use. So ketamine is preparatory for what's coming here, and I'm hopeful that maybe by 2024 we'll have some better insight in terms of what if MDMA will be available or not. I hope it will. I think shortly thereafter it'll be psilocybin. But we need to be vigilant about this. We need to be deliberate about it. At the Alma Institute, we are very deliberate about it, as well as the organizations I belong to, the American Psychedelic Practitioners Association, APA. We're also very deliberate about bringing in BIPOC members and holding space for BIPOC members and training and advocating for training more BIPOC members in this space, not just to do clinical work, but also in leadership roles and other areas that as this profession begins to expand, because we're a new profession, we're a new discipline. So I'm hoping that because we're having these discussions early, and I think that within this space, there's a lot of good intentional people. I think we can make some significant inroads, whereas others have failed. That's my honest hope. And I don't know if it'll come to fruition, but I'm hopeful that it will.
That's excellent. So many great initiatives happening there. And, a question here from Sandra in the audience. She's asking, how do you feel the training content ought to be changed to be increasingly anti-racist?
I don't know.
Okay,
so
yeah.
I don't know which program which program you're talking about. If you're talking about the MAPS program or what specific
Just
program?
in general, is there specific content modules that you see? You mentioned leadership roles training, but is there additional content specifically?
So each program out there who are training facilitators, they have their own curriculum. Many of them talk about diversity and inclusion, DEI, but when I look at their curriculum, I don't see much of that there. I see a couple of things here and there, but no real attention paid to it. I don't see any BIPOC members on their staff teaching any of this stuff, so I'm not sure how that's working out for individuals. Let me tell you, again, I hate to brag about these people, but I just have to brag about Oregon real quick. Oregon is really fascinating to me. So if you know much about Oregon, what they've done with Measure 109, their psilocybin law, part of their requirements to get licensed there, really interesting. They want you to do a social equity plan. So you get the licensure, you get your license. So part of your licensing package is with this social equity plan, right? You have to demonstrate, right, your commitment to equity, diversity, and inclusion on some measure, and be able to demonstrate that you're living up to that measure, right? And so I don't know how on earth they're going to, see who's doing that or who's not doing that. But when I discussed this with some of the officials there, they had a meeting last week there in Oregon about this. I went to the meeting actually. It was pretty cool. They talked about bringing in more information and sort of refining the law as we go on. There's a lot of things we don't know, but I find that really interesting. So at our program at the Alma Institute, we're all about equity, diversity, and inclusion. If you look at our curriculum, what we're offering our students there, we are BIPOC issues are at the center of our pedagogy. And so a program that says that they're about diversity and inclusion, and yet people of color are not at the center of it. I'm not sure what they're really doing. More so reinforcing the things that we really are trying not to reinscribe. So if you're not talking about racism, if you're not trying to end racism in some way, right, then maybe we need to look at our own racism, our own practices, and see what we can do to be better, to end it.
Yeah, absolutely. When I was working at MAPS, we participated in a training by the Catalyst Project. I'll drop the link in the chat here. They're a group in the Bay Area, and it was, 2 or 3 day workshop that was very enlightening for all of us. We all walked away learning so much and just a better understanding of each other. And, from that came some working groups for the staff to continue the work, because it's not, in my opinion, just to do the training once. It's then how do you change your behavior? How do you put that into practice in your organization, your life? So I'll drop this in, and I'm sure there's other groups that offer this type of program. And it would be amazing to see, more of this just incorporated in psychedelic therapy training, but all angles of mental health care training. And I agree with you. It's not taught in school so much. Same with ethics. The psychedelic space, I think, is really trying to highlight what psychedelics teach us, that we're all connected and that we need to look at our own shadow sides, look at things we're not being consciously aware of, or even deeper, what are we consciously aware of, and how to shift those behaviors. So
that's right.
Yeah, so I'm going to shift the topic a little bit. There's a question here from an audience member, which I think is a really compelling question to ask you. So as a little bit of context, Usama is a Black biracial therapist and was fortunate enough to be chosen as a MAPS equity scholar for the MDMA-assisted psychotherapy program. And conversations around race and psychedelics were definitely present. So she is asking if you have heard anything about a BIPOC practitioner working with a white client who's under the influence of a psychedelic medicine, and a racist part of the white client comes out, and this may lead the client to ask for forgiveness from the BIPOC clinician. So the question is, how could a BIPOC practitioner effectively serve the client while not harming themselves in the process of those moments?
Okay, that's a really good question, and that's a very I don't know how to answer that, because it's going to be different for each individual person. But I would say for me, this is how I deal with it. This is how I come to understand it. I just assume. It's not an assumption. From my training, I know that as much as I love my white brothers and sisters, they're racist, right? I mean, they can't help it. And the reason why they can't help it is because we were born in a society that was racist to begin with. Now, let me qualify what I mean when I say racism. I'm not talking about burning crosses on folks' lawns, calling people the N-word. I'm not talking about that, right? That's interpersonal racism. What I'm talking about is the benefits that accrue to white people because they live in a racist society, right? And if you want to know what those benefits are, I would really encourage you to read Peggy McIntosh's fine piece of work, The Invisible Knapsack. She gets into this and really kind of, I read Peggy McIntosh's work almost 20 years ago. And when I read it then, it was just an article that had come out. But of course, it's been cited, millions of times now. It was like a moment. Because up until that point, white people didn't have a way to consciously think about how their acts rose to the level of racism. Most whites didn't understand that racism was beyond just individual acts of meanness. So when I say white people are racist, what I want to be clear, what I mean is that white people benefit from the spoils of living in a racist society, never having to worry about being stopped because you're driving Black, never having to worry about people following you around in a store, right? Never having characterizations cast upon you simply because you're a person of color. All the indignities we mentioned earlier when we defined microaggressions, right? Not having to worry about all of these things that continue to manifest is a huge, huge a burden lifted off white folks, right? And so whereas people of color have to deal with that day in and day out. So when I talk about racism, that's what I'm talking about. White people benefit from systemic racism and institutional racism, which makes them racist in a racist society. It makes a lot of sense, right? Then people say, well, can Black people are racist too? Yeah, Black people believe the shit that's said about them too. They believe it, right? Why do they believe it? They're hearing it from the same sources that white people hear it from, right? And then you have people who are politically on the right who are trying to stop the discussion all along, basically by saying white people are too soft to have these discussions. We don't want to talk about these things because white people are too soft. You're going to make my kid hate himself. Please, please, right? The hypocrisy, please. So we have to have these difficult conversations if we're to get any further ahead than what we currently are. And we have to not just have conversations, but do things that are affirmative. One would be, how about change your friends? If all your friends, most white people like to overestimate their friendships, right? Of people of color. And if you look at 100 people, 91 of people who identify as white, 91 of their friends look like them. They have one white friend, one Asian friend, one Latino friend, but very, very small stretch of friends that look like them. People of color, very different. A lot more friendships than white people have. So spread your wings, get to know people who don't look like you, right? That's a start. Don't sweat the small stuff. The whole idea of white fragility, right? Robin DiAngelo's work is powerful in that it really does capture this tension that many whites have when talking about these things, right? And so, and if you feel, and if I say the word racism and you bristle at the word racism, then maybe you need to go look at, maybe understand what that looks like, or have a conversation with a trusted friend about it, or maybe read some of what Allison's posting in the chat box that might be of interest to you. But seek to learn, and as we learn, we begin to unlearn, and that's a process. And it's not a one-off process, it's a process, right? So I'm still unlearning. I am still unlearning what white supremacy has told me I'm supposed to be.
Yes, always on the path to learning. I do want to take it back to this question though, about these experiences that might come up. Altered states could be amplified, or this therapist is mentioning this concept of our personality perhaps having different parts, and not that this is a disorder like a multiplicity disorder, but that maybe there's different parts of the psyche that sometimes are repressed or sometimes can come forward in different ways. And perhaps under psychedelics, it's understood with these models of internal family systems, that these parts might become more activated or more vocal. So how might a clinician that faces something like this, where might they find support? Or how are there any techniques for, if you're in the moment of something like this, how to handle an uncomfortable situation? Or how would you deal with a client like this?
I'm still stuck on the last thing you asked me about. Somebody, something racist comes up in the middle of a session, and the client is white, and the facilitator is a person of color, a biracial person. How do you deal with that? You have to. What I was trying to get to is, in that long-winded thing I said earlier, is you have to be very, very comfortable in your skin. One, very secure and resolute about your knowledge of racism, your understanding of what it is and its history and what have you, and have some insight into human behavior. And what I was going to say is that I don't hope if someone says, "Oh my God," so the N-word comes out, right? Now, I would hope that I wouldn't freak out in the middle of the the session, because it's not like first time I not heard the N word before. I would think that I would hold space for that person and maybe take some notes about it and what issues came up during that the outburst, right? It's something we can revisit during a very powerful integration session, right? But right then wouldn't be the time, to do anything but to sort of, whoa, whoa. So the person who's doing that, I would invite, anybody who's listening to us today on this most amazing podcast or discussion we're having here is really quite wonderful, and the crowd is so active too. I love it. Is to do a lot of inner work before we're working with people who these issues may come up. Now, for me, being holding space in a sometimes these things do come up. I've had quite a few white people who've asked me, would you ever have a session with whites? Would you ever do sessions with white folks to help us unlearn some of this stuff? And I said, I would hold space for anybody, who's interested in doing that. But I don't want to say what I'm trying to articulate this in a way and say it in a way. I don't hate white people. People say you hate white people because you say they are racist. I don't hate white people. I don't individually know any. I hate white supremacy, right? And that's what my MO and my jam is about, is trying to end white supremacy. And so what I would advise therapists and facilitators to consider is to think about their own inner work before they would take on some of these more weightier issues such as race. So.
Absolutely. It's so important. The inner work and the possibility of transference, countertransference to come up during psychedelic therapy sessions. It's amplified that potential. So, I also see the ongoing consultation between people that are holding space, whether it's therapists or guides, to have those resources of community to unpack some of these things that might come up in sessions. So we're looking forward to launching pretty soon a peer consultation platform to allow people to make those connections and have some resources that Kylie Taylor is putting together to enable community-based consultation and less of a hierarchy of experienced practitioners working, mentoring new practitioners, but more of the resource of sharing amongst colleagues or peers. So there's
that's a great
a big need for that.
Is Hanifa involved in that? Hanifa Washington, is she involved in that project? This is something different.
It's something different, but it's the materials we're putting out, and we're going to pilot something, and it really is to be more peer-based than us sort of organizing these groups, because the need is so large for for those people to connect. It doesn't need to cost a lot of money to do that, in my opinion. If you want to lead a group and host your own group, convene one, then we just want to put the resources out there for practitioners to be able to do that. So, we have time for just a few more questions here, and then we're going to wrap up right at the hour. But one piece we didn't talk too much about is why is it important to include lineage keepers and traditional healers in this psychedelic space and conversations that we're having?
So our lineage keepers and our traditional healers are probably our most experienced guides that we have. We have to find a way to bring their work into the light so that they can be able to work above ground and be able to do the great things that they're doing in healing people from all manner of afflictions. So it's important that we bring these diverse voices into the space, so it's just not one thing, but it's amorphous as we're developing our ideas, or as we're developing our profession. We want our profession to be completely inclusive. And so one of those inclusive notions would be making sure that we reserve space and hold space for our lineage keepers. So yes, we need to have our most experienced, if not working with clients, but also in the classroom teaching future facilitators and others who are in this So I'm a big advocate of that, of bringing our elders. And one of the things I've mentioned too is with regards to APA, that's one of our charters, is to somehow provide a pathway for our lineage keepers to have something that they can hang a shingle up and actually practice their craft without worrying about being arrested or accosted by law enforcement.
Yeah, absolutely. I really hold these different frameworks as all being really valid approaches. The medical model, more of a community or church-based model, and then potentially other ways of group work or people coming together in community. They all seem like will play an important role in how people can access psychedelics and plant medicines that grow from the earth. And Indigenous people have used them for so long. We need to make sure that we don't take this knowledge and just change it and make it our own for our own purposes, particularly for not just profit-based motivation. So,
but isn't it great though, Allison, to be in a new profession? To me, we have such an opportunity here.
Absolutely. It's so exciting. So exciting. And it's great to see a lot of resources coming forth too. I just wanted to post this Black History Month we're celebrating right now. And MAPS put out this resource, which includes a playlist of Black artists and a number of other bulletins and articles that they put together on this page that if anybody wants to check out, you can go to the link there. Also posting again, if you want to connect with Darron, we have his LinkedIn here. Somebody was also asking if you have a website.
I'm not that sophisticated yet.
That's quite all right. LinkedIn works well. Because I know that this is just the beginning. We are at the beginning of this psychedelic therapy renaissance journey. And like you said, we are having these conversations early, and I'm really grateful for that. And that people like yourself are coming forward to show us the way. And help us
you as well.
Stand. Yes. There's a lot of good intention, but we need to put that intention into action.
That's right.
With our work and with serving the communities that could really benefit the most and probably really could need this help and support for ancestral healing, for our cultural healing. That's and what I think the promise of psychedelics really is greater understanding of our connection to each other and this world at large. So
thank you. It's wonderful.
Yeah. Thank you so much. I'm going to go ahead and wrap it up now. We will share the video after. And if anybody needs CE credit for our webinars, I posted the link there. And thank you so much for your time. We're going to put out all these resources that you shared along with the video so that more people can benefit from this conversation that we just had.
Thank you very much. Appreciate you. Thank you, audience. Thank you.
Yeah. Thanks, everybody. Thanks for being here. See you next month.